Jenny, I think, is going to talk about a practical case control tool, or the development of a case control tool that programs can use for identifying high-risk populations.
Thank you for the introduction. So yeah, my name is Jennifer Smith, and I'm a postdoctoral scholar at the Malaria Elimination Initiative, the Global Health Group at UCSF. Adam has already outlined a conceptual framework for defining high-risk populations and really highlighted the variation in these populations and underlying risk factors between different areas. So what I'll be discussing today is the use of a case control study methodology to identify these risk factors in order to target interventions to these populations. So just a brief overview of my talk. I'll be discussing an overview of the epidemiology of malaria and elimination settings, and then the key questions, gaps, and opportunities for risk factor assessment in these settings, before overviewing case control study designs and discussing a prospective health facility-based study in Namibia that was conducted and led by Dr. Hugh Sturrock at UCSF. And then finally, because what we really want to be thinking about is how these methodologies might be applied in different settings, I'll be discussing the challenges in the use of case control studies and variations in the design that can help to overcome some of these issues. As the map of malaria endemicity shrinks, more countries are progressing from low-controlled endemic status to pre-elimination and elimination settings. As this happens, malaria transmission is increasingly unstable and becomes clustered into hotspots, or areas of small geographical risk, and high-risk populations which share geographical, socioeconomic, or demographic characteristics. As strategies shift from control settings to elimination, we want to target interventions and move from a population-based approach to a more targeted individual approach. And similarly, we're moving from defining broad categories of risk groups to a more local definition that recognizes the complexity of risk factors in different settings. So a challenge here is that while in control settings, we can use population-based prevalence surveys, mass screenings, and cohort studies to look at risk factors. In elimination settings, where we have very few cases, these studies are underpowered to assess risk factors, which is why we want to be looking towards new tools and methodologies that we can flexibly apply in these settings. So Adam highlighted some of the programmatic questions that really need to be focused in order to target these interventions. So what are the socio-demographic, occupational, and behavioral risk factors for malaria infection? How are travel patterns associated with infections? And how best can we design and target these interventions? In elimination settings or low transmission settings, incident cases may be less than 5 per 1,000. Also in these settings, PASM surveillance systems are being strengthened. And in many cases, case investigation is already happening. And cases may also be geolocated back to their village of residence, for example. Now, this does give programs some information. So case profiles, which sort of define the characteristics of cases, and maps of the distribution of cases may be available. However, we're lacking an appropriate comparison group. Now, some good clinicians, they may be aware of the underlying distribution of these characteristics in the general population, and they may have a pretty good idea of what some key risk factors are. However, in other settings, this isn't known. And even if this is known, maybe we want to drill down deeper and be looking at specific behavioral exposures or occupations. So in that case, we need to be looking at flexible, locally targeted, and cost-effective programmatic tools to assess risk factors in these settings. So case control studies, as Adam mentioned, are a classic epidemiological study. The diagram on the left here just displays that cases will arrive from cases arise from a source population, which in a programmatic setting is probably a dynamic population, where there are births and deaths and people immigrating. Controls, then, should be representative of this same source population from which the cases arise, and they may be selected either matched on time, that is, as soon as the case arises, then a control would also be selected, or unmatched on time at any point during the study period. And which option you choose depends on whether these exposures vary over time. This is one factor. So there are a number of advantages and disadvantages to case control study. They are very cost effective. They're efficient for looking at rare diseases. Where surveillance systems are strong, the use of routinely collected data on cases can already provide some information. That's half of your case control study there, maybe. And in addition, they're very flexible designs that can vary with the level of external support and program capacity. However, case control studies have a well-documented susceptibility to bias, in particular in terms of the selection of controls and definition of that source population, and also recall biases when assessing exposures. And so you might envision that if using this as a programmatic tool, it should be done with technical support, because the design of them can be quite complicated in certain settings. And in addition, case control studies can be inefficient to look at rare exposures. And so in those types of settings, you may want to target your case control study to populations where these exposures are more prevalent. So there are a handful of case control studies that have already been done in malaria, and I've just highlighted two here. The first one looked at it was a health facility-based case control study that identified male, gender, and travel to be associated with Plasmodium falciparum infection. The second study I have here is actually a recently published protocol that's looking at risk factors for Plasmodium knowlesi in Malaysia. And this study, in contrast to the first, really focuses on behaviors leading to increased exposure, either within the forest or interaction with monkeys. And in that case, they match their cases and controls by village, which sort of achieves control of confounding for socioeconomic factors that may be difficult to get a good measure of. So just to think a little bit more about how formulating your case control study design can be tailored to programmatic requirements and also to the existing level of knowledge that you have. So where programs have an idea of what the risk factors are generally, you may have, for example, males who travel. You may have a more focused study in order to define high-risk networks and potential targets for interventions. However, where you have little knowledge about the risk factors in a setting, you may want to look at a wider geographical scale and assess a broad array of risk factors in order to do a more exploratory risk factor analysis and maybe risk mapping, where you would select a representative distribution of controls. And I'd like to quickly discuss a recent study that I mentioned was led by Dr. Hugh Sturrock. That was conducted in the northern districts of Ngela, Otapi, and Oshikuku in Namibia. The study was done in collaboration with the University of Namibia and the Namibian Ministry of Health and Social Services. Now, these areas have a high historical burden of malaria, but the burden has declined over the last decade. And it's suspected that travel to Angola was an important risk factor in this area. So the aims of this case control study was twofold. First, to identify risk factors to better target interventions, but also to really look at the programmatic and operational issues in doing case control studies in order to think, moving forward, how we can address these issues and come up with more generalizable guidelines in different settings. So this study was cases were recruited from health facilities who were RDT positive, and community controls that were representative of the general underlying population in the district were selected. This is an overview of the study design. So 51 health facilities, cases were recruited at 51 health facilities, and community controls were randomly selected within approximately 2 weeks of a case. Following informed consent and follow-up at their household, a blood sample was taken, and an individual and a household questionnaire was asked in order to assess risk factors at these different levels. And the study spanned 2 transmission seasons between December 2012 and July 2014. So I'm just going to, the analysis for the study is ongoing, so I'll just present some preliminary results today. And there's a poster tomorrow, which I give the number later if you'd like some more detailed information. So the final sample size was 99 cases, which included 547 controls that came from 131 households. So the figure on the left just illustrates that the age distribution for cases was slightly older, and there were maybe more males than females. Reported net ownership was about 73% in the population, but having more than or equal to 1 net per 2 people was much lower, about 33% in cases and 37% in controls. Reported net use was also low, and about 30% of the population, as was IRS coverage. We used multivariate logistic regression models with generalized estimating equations to adjust for household clustering and robust standard errors. So a number of individual and household level risk factors came out of this analysis. We found that cases were more likely to be males in age 15 to 29 years. In contrast, cases were less likely to be aged 60 and over. Cases also had a higher odds of traveling, including traveling to Angola in the previous 6 weeks, spending the night outside of the district, or sleeping away from the house the previous night. In addition, cases were more likely to seek treatment for the previous fever. Household level risk factors, cases had a lower odds of net ownership and of the sleeping structure being painted or replastered in the last year. In addition, cases had a higher odds of having no window coverings or no windows, so possibly they're spending more time outside and they don't have window coverings to protect them when they're inside, and were more likely to be recruited during the high transmission season. The key discussion points that I want to take away from these preliminary results are the possible programmatic implications. One objective might be to improve targeting of net coverage. It was low in both cases and controls, which obviously it needs to be scaled up and perhaps targeted better to high-risk populations. Housing modifications, including ensuring that houses have windows and that there are screens in the windows, is another option. Alternative interventions might be considered for populations that are traveling a lot and are not using nets when they're outside of their homes. And finally, these populations, perhaps who are traveling, might be an important target for network studies or to get more information about the types of exposures that they're seeing. However, there were a number of challenges also that we found in this study. Concurrent selection of controls was challenging, which accounts for probably the higher odds of being recruited during the high transmission season if you're a case. There was a greater case burden in these times, and so because we were following up these individuals at their households, it's more difficult to select them concurrently. And secondly, it's important to consider alternative control groups. So we selected cases from health facilities, but it's possible that depending on the level of access that this population has, that there are different selection factors for cases and controls. So this is something that we look at in the poster tomorrow, which is number 3447. So just to highlight a few more challenges in study design and options that we might have moving forwards. The sensitivity of RDTs is known to be low and might introduce misclassification both of cases and controls if they have low density infections. Using a more sensitive diagnostic test could be an option in some settings, but it may be more time consuming and costly. So trying to integrate that within a programmatic setting might delay the response. In addition, cases and controls, cases who have low access to health facilities. Alternative methods either actively detecting cases from the population or using health facility controls, matching controls, or using networks in order to nest the case control study within networks might also be an option in those cases. And finally, in terms of assessment of exposures, which might be a potential source of bias, it's important to ensure timely follow-up to minimize recall bias and ensure comparability between cases and controls in case these exposures vary over time. And finally, in cases where there are rare exposures, so for example, travel to Angola was a rare exposure, but because the association was so strong, it did come out in the multivariate analysis. However, there may be other potentially important risk factors which are low prevalence in cases and controls, in which case a more targeted case control study within a network might be able to increase the power to look at these types of exposures. So current studies, as Adam mentioned, we're doing some work in Zambezi region, Namibia, where we'll be conducting a health facility-based case control study. And this is focused on looking at occupational risk groups and high-risk behaviors. In addition, in Vietnam, we'll be using a slightly different strategy, which may utilize community health workers to identify cases in villages and to specifically look at exposures related to forest malaria. Thank you very much. Just to acknowledge all of the people who have contributed to this work.
Thank you, Jenny. Have we got any questions?
Thanks so much for your talk. That was great. I'm Adam Akulian from University of Washington. Curious about if you had repeat cases and how you dealt with that. Was it just the first case? Did you have multiple individuals forming your case series?
I don't think that there were any repeat cases in this study. There were a few cases that came from the same households, but no repeat cases.
Okay, thank you very much. Thank you, Jenny.